Now I'd like to invite Professor Mira Agar to the stage, talking about medicinal cannabinoids for appetite loss and related symptoms in advanced cancer. Mira is a Professor of Palliative Medicine at the University of Technology, Sydney, and a palliative care physician in southwest Sydney. Her research includes evaluating new therapies using clinical trial approaches for symptoms in advanced illness and models of palliative care services to better meet the needs of people with advanced illness. So another big-hearted person, please welcome Professor Mira Agar to the stage.
Thank you, and I'd like to thank Lucy and the organising committee for an opportunity to share with you some research and our thinking around a particular distressing symptom in people who are living with palliative illness. So, as you would know, loss of appetite is a really common symptom for people, especially people with advanced cancer, but I think it also impacts on a large number of people living with far advanced illness that is non-cancer. And this affects 9 out of 10 people in the final stages of cancer. And when it does occur, the severity of that symptom is moderate to severe. And as a palliative medicine physician, we don't see symptoms as just a medical manifestation of illness. Every symptom comes with a social meaning. And if you think about sitting down at the dinner table and having one person who is not able to engage in that meal, who responds to the meal that someone spent time preparing, being unable to eat, there is a huge social impact of that inability to eat. And the meaning of that visible sign of decline and associated weight loss and the function impairment that occurs means that this is a symptom that is much more far-reaching than just a physiological response. So I think we speak to families daily who feel this sense of incompetence that they've tried to get the person to eat. They've asked them what they want to eat and then gone and cooked that meal, and by the time they've done that, the person no longer is able to even see that food, let alone put in a mouthful. It makes people really socially isolated. They're very embarrassed when they're going out in social environments that they are seen to not be able to engage fully in that. And I think there's a real sense that not being able to eat and the meaning of that imminent death is really a profound experience for our patients. And the pathophysiology of the anorexia component I think is an area which is evolving. There's often been a lot of focus on the weight loss as a physical and physiological manifestation, but it's the symptom of the loss of appetite that we're particularly interested in because of the distress and the social meaning of that symptom. So we know that there are local causes within the gut and the inability to swallow, but we also know that tumours produce a large number of substances which also can alter food intake. And alteration in nutrients, zinc is one example, also can have an impact. Mood changes also impact on central neurotransmitter processes. We know that the pain pathways also can interact. And there are a number of central neurotransmitters that are directly involved in appetite and food enjoyment pathways, such as ghrelin, are also altered in people who have advanced cancer. And I think this story around inflammatory cytokines is something that we're very familiar with in palliative care, where many of the symptoms, and cachexia and anorexia are two of those, where inflammatory pathways are really very fundamental to the reasons that those symptoms manifest. And this is one of those last frontiers, I suppose, in terms of symptom care, that the current treatments that we have, which are progestins and corticosteroids, if we're talking about just the medicines aspects, really are limited when we talk about the improvements in appetite, if we think about that element on its own. And many people experience quite a wide range of side effects with corticosteroids, and in progestin's case, the risk of thromboembolism is the concern. So what is the data really to suggest that cannabis might work in improving appetite for this group of patients, and more particularly not just improving the ability to eat, but in improving the enjoyment that's associated with that? So some of the theories, and there's some animal data that helps us sort of unpack this, is that through its CB1 action, that the palatability of food is changed and improved, and that anandamide might also act as a hunger signal in these patients, and that we're not only just stimulating appetite, but there seems to be an impact on taste and the pleasure value of food. And I think the whole area of impact on pro-inflammatory cytokines haven't really been studied in this particular patient population, but it's an area of interest in anorexia, cachexia research, and is a very rapidly evolving area. This is some data from a phase 2 trial that was looking at HIV patients who had neuropathy. And the researchers really took the opportunity to do a sub-study in 7 of those participants, really to try and see whether they could look into the levels of neurotransmitters and chemicals that are associated with appetite pathways. So they found that there was increased in ghrelin and decreased levels of the gut hormone peptide YY, which are in the right directions in terms of improving appetite. But increasingly they saw that leptin also was increased, and leptin is a satiety hormone which essentially tells you to stop eating. So there's still a long way to go to sort of try and unpack what's actually happening in terms of the appetite pathways. But they thought that possibly it was because of the initial stimulation of appetite, people's caloric intake was increasing, and the negative pathways to stop us eating happen quite rapidly. So the window to try and capture these changes from the moment you feel hungry to when you start eating to when you stop feeling hungry is quite a rapid process. So to capture that is quite tricky. So the prior studies in HIV have led to dronabinol being listed for the treatment of anorexia associated with weight loss, and I think that whole distinction between weight loss and loss of appetite, I think, is a really important one to think about. And the challenge, I think, in thinking of how that might relate to clinical practice in other areas is the short duration of treatment. And we now have antiretroviral therapies, so how does weight loss in that situation from a pathophysiological point of view differ from the situation very early on in HIV where those treatments weren't available? And really the signal around appetite is very difficult to ascertain from those studies. And HIV, from a point of view of how the loss of appetite is mediated, may be quite different to how that occurs in people with cancer. So in terms of the studies in cancer, there are 3 clinical trials really in this area. The 2 initial studies on the top of those slides have used THC cannabis extracts compared to placebo. And both of those really looked at appetite as a singular symptom, and both of those didn't show any benefit of that oral extract or dronabinol in comparison to placebo in the first trial and migestrol, which would be one of the current therapies. And I think the challenge with those studies, it really makes us rethink in terms of what are we actually trying to achieve from a biological perspective. And the reason I showed you those slides around the ghrelin level changes is that we're talking about something which we want to actually mimic what happens in our normal hunger pathways, which is a very quick, very rapid change in those levels responding to the timing when we want to eat. And I think the 2011 study from Brisbois' group, which is a Canadian group who has been doing a lot of work in the area of anorexia and cachexia, really thought, let's think this again. Now, is it appetite that we're actually trying to change here, or is there something else that's happening that patients are talking to us about when they say that they feel that they can eat? So they took quite a different tact. They really felt that maybe it's around the taste and smell of food, and for any of those of you in the audience who have had experience talking to someone with cancer or care for people with cancer, know that people will say, the things that I'm eating don't taste the same. The smell of food is enough to put me off. And they will say that I can no longer eat quite a number of groups of food. And so they found that people had improved chemosensory perception, which is the taste and smell of food, and the appetite before the meal increased, and people were able to increase the amount of calories they consumed as protein. And for the palliative medicine people in the audience, you'll be very familiar with people saying that eating meat is something which really is very tricky for people with advanced cancer. And in terms of secondary outcomes, they also found improved in quality of sleep and relaxation. So I'm just going to outline to you, similar to Sue, really the way we're using this prior data and what our patients are telling us to really inform the trial that is currently underway in New South Wales. And I'd like to really acknowledge the participants in our trial, and I think their ability to put themselves in research when really the drivers, I think, for people who participate in palliative care studies is to help other people who may be in their situation in the future is really very admirable. And so what we have set out to do in a phase 1-2, so an early phase trial similar to what Sue has described, is to look at pharmacokinetics, so measuring what happens to cannabinoids in the blood, and the dose response of those to a vaporised botanical flower bud product in advanced cancer patients. And similar to the Brisbois study, we're looking at appetite, but a whole range of other related symptoms, so taste, smell, hunger, food enjoyment, and that sensation of feeling full. And looking at what food intake and the types of food people are able to eat, and also a broader range of quality of life measures. And we're asking people to rate all of those, but also the side effects that they're experiencing or don't experience. We're also including a qualitative component to our studies, and most of the palliative care trials that we do in Australia, we include a sub-study where we actually sit down and interview the participants and actually try and unpack in depth a range of experiences within those trials to really try and understand what our quantitative data is telling us. So similarly, just to give you an idea of how these trials are constructed, we're looking at people who've had at least 2 weeks of anorexia in the setting of advanced cancer, and people who have had optimisation of the treatment of the causative medical symptom, but we're not requiring people to have had to have tried or been refractory to those other treatment options. All we're saying is that if those treatments are not right for them, regardless of the reason for that, they can enter into the trial. The exclusion, similarly, is really in this early phase work is to just make sure that we've included a group of people who are reasonably stable to help us really try and understand these parameters so that we can take it forward into the further phase 3 work. And we're not restricting the prior psychoactive medication use. We try and keep that stable within the trial period to just help us interpret the results of changing just one thing at a time. But I think it's very difficult to say that if you are on other treatments, say for your cancer pain, that you have to be taken off all of those or not be allowed to participate in a trial. Because I think this is the real life clinical scenario that clinicians and patients need to try and understand how this product may be useful in improving anorexia. And we know most people with anorexia, that's not the sole symptom that they will experience. People are allowed to also be on chemotherapy and radiotherapy or endocrine therapy for their cancer similarly. So that is really just saying the same. And I think opioids, benzodiazepines, antipsychotics and antidepressants are not uncommon in this patient population for a wide range of symptom issues. And there are many people who will want to continue those. There are many people that also are seeking alternatives, but I think we're really just saying that people are allowed to remain on what they choose to remain on at that period of time. So again, similarly, the study is being done in an inpatient setting. We do the baseline assessments on the evening before the study starts, and people are having the study intervention 3 times a day, an hour before their meals are offered to them. There are different doses on every day, and at the end of the 7 days, we do a semi-structured interview with the participant themselves and their carer if they're willing. And there's quite a detailed follow-up period by phone up until day 10, and further if the patient or the clinician have any particular concerns. And the dose is varying between 8 milligrams, which is about 1.08 THC, to 48 milligrams, which is about 6.48 milligrams. And the PK sampling is really around a morning dose, and within that first 60 minutes following that dose, and we're correlating that to the appetite change at exactly those same time points, really to think through the logistics of when you have your dose and when the appetite stimulation may be seen. And you would think that trying to get a meal to a patient in hospital at exactly the right time in this type of study would be very straightforward, but trying to get timing of meal times in hospital, we learnt, is a difficult challenge. But I think one of the things, as Sue said, people who are willing to support and think through some of the logistics of these studies come in all sorts of surprising places, and we've been working really closely with food services, and I think they've been really happy that people have been interested in the value and the role that they play in caring for patients. And not many researchers actually go and speak to food services and hospitals, and I think we may have been the first people to do so. Our pharmacy colleagues have also been incredibly helpful in thinking through the logistics of how storage, dosing, dispensing to the ward environment, storage in the ward environment, use within a ward environment would work not only just in the research setting. I think everyone's trying to think about how this might work also in the clinical setting. So the trial really informs practice, and practice informs the trial, and those two things I don't think have been separated in the way that the research team working with us have been thinking about this trial. We're using a Bedrocan product, we're using Bedrobenol. And the THC content is about 13.5%. And I think the other good thing is that we have some information about the terpene content of that product. And we're using a placebo, which is manufactured from the active Bedrobenol, and then the specific terpene profile is then restored. I suppose we can have a discussion about whether, in the sense, whether that's a terpene product rather than a placebo product per se. But I think it's really exciting that placebo products are available and we can actually try and take some of these questions that patients are talking to us about into these sorts of research frameworks. And I think the things that we really think that this trial is tackling is that we're aiming to explore a question which cancer patients are asking us to explore. I think in palliative care research, this is not a new idea for us. Most of the questions we take forward in our research are questions that our patients tell us are important. For example, we've done a lot of work looking at people who want to be cared for at home when they're in their last days of life, and healthcare systems are really not configured to really enable that way so that carers and patients feel well supported in their homes to achieve that. And so a lot of the research we've done is to try and unpack how that could be done better and give those patients a voice and argue the case for why services need to be reconfigured around them. So I think a lot of research that we do is really aiming to bring data to questions that patients are putting forward to us. We're really trying to tackle a broad range of symptoms, not taking appetite as just a singular medical symptom. And I think the practical aspects of dosing, packaging, hospital use, we know palliative care patients may be receiving some of their care at home, but for many reasons they may need to be in hospital and they may need to be in a palliative care unit, and research needs to try and inform all of those practical aspects as well as trying to unpack the efficacy questions. I think it's really about thinking about the biology of the symptom, which is why I sort of took you through what our current understanding of anorexia in this patient group is, and optimising the delivery of what you think is the therapeutic agent fitting in with that biology. So we're really trying to see if we can optimise the THC levels around meal times, and if that's the way patients are trying to use the medicinal cannabis, doing research to help understand how that might work. And I think the other issue is that we don't have meals like in hospital at 8, 12 and 6. If we want to get up on Sunday and have breakfast at 10, which I think some of the audience members have decided to do today, meal times are spontaneous and a social activity. Meal times are not a medical activity. Suddenly when you have cancer, it becomes a medical activity. And I think we're trying to think about ways that we can return it to being a spontaneous social activity where patients can share that meaningful time with their families. And really using a full spectrum product, I think, trying to understand whether that is where some of the other appetite trials have failed to show a benefit in cancer patients. Thank you.